let us go further to our next speaker, Dr. Ritu Chadha. Dr. Ritu Chadha is Associate Director. Dr. Ritu Chadha is Associate Director, Hematopathology, Vedanta, the Medicity, Gurugram. She is 21 years post-MD pathology and she has more than 16 years of experience dealing with clinical flow cytometry. She, to her credit, has 2 international trainings, one in flow cytometric MRD at NHU, Singapore, and she had been a visiting consultant at Mayo Clinic and Cellular Immunology and Molecular Lab for primary immune deficiency disorder panels. Her areas of interest include development of new tests in flow cytometry for leukemia and lymphoproliferative disorders, minimal residual disease in leukemia, CLL, and myeloma, primary immune deficiency disorders, supervision of internal and external quality control in hematopathology. For molecular hematology, she is trained in metasystem on ISIS and Icaros software for karyotyping and fish analysis, and molecular hematology, Quant Studio 5 DX real-time PCR and next-generation sequencing on Iron Terrant, Gen Studio S5 and Illumina Next Sequence 550. Certified for lab management and internal audit as per ISO 15189 22 for medical laboratories. Have received good clinical practice certificate by NIDA Clinical Trials Network for Medical Research, NIH. She has 25 publications in index journals and 2 book chapters. I now welcome Dr. Ritu Chadha for our next topic in this series of plasma cell disorders, which is prognostication of multiple myeloma. Over to you, Dr. Ritu.
Yeah, so thank you, Dr. Sabina, and thank you, Dr. Komal, for giving a wonderful talk, and Akshata from Kaho for inviting me. So is my screen visible like a slideshow?
Yeah, your screen is
Yeah.
visible, Dr. Ritu.
Yeah.
Inside.
So I'll be talking on multiple myeloma prognosis. So is the top part of the slide also visible?
Somehow it looks to be zoomed out a
Zoomed
bit.
out, right. So I'll keep it like a smaller version then. So yeah. So the data from the real world studies show that overall survival of myeloma is over 10 years in transplant eligible patients. And among elderly patients, more than 75 years, the median overall survival is lower and is approximately 5 years. So after we have kind of understood how the patient of myeloma is diagnosed, we need to kind of prognosticate the patient in the OPD and understand what are the risk factors for overall survival, and the clinical and the lab evaluations need to be done for that. So myeloma is a heterogeneous disease, and nowadays the prognosis has come to more than 10 years as compared to the previous decades. So this is a overall survival curve where in 1980s the prognosis used to be only 22 months. With the progress in the treatment, now the prognosis is almost 8 to 10 years. The prognosis depends on the host and the tumor factors. The overall prognosis is affected by host characteristics, the tumor burden or the stage, the biology of the tumor like cytogenetic abnormalities, and response to therapy. So we know it is just like for any other malignancy. We need to stage the malignancy, understand basis the biology of the disease and the response to treatment. The prognosis will depend on all these factors. The patient-related factors are age. So the median age of patient at diagnosis is 65 years, with 1/3 of patient presenting more than 75 years. In India, myeloma occurs in younger age group with a median age of 56 years in a study published by Dr. Ritu Gupta et al. And performance status is important. So ECOG performance status and Karnofsky's performance status are done by the clinical team. The frailty score combines age, comorbidity, cognitive, and physical condition and identifies 3 groups like a fit score is 0, intermediate fitness, and the frail score more than 2. The revised myeloma comorbidity index, which includes 5 parameters like renal disease, lung disease, age, frailty score, and KPS. This is the scoring is done based on the patient-related characteristics. The tumor burden or the stage. Now we have this traditionally, we know that Dury Salmon staging system and international staging system, which are now obsolete. However, they served their purpose in 1975 till 2009. So these were the Dury Salmon staging system, which included a lot of biochemical parameters. And international staging system was a very nicely identified only two markers, serum beta 2 microglobulin and serum albumin, the cutoff being 3.5 milligrams per liter beta 2 microglobulin and more than equal to 3.5, and there were three stages. So the understanding is that beta 2 microglobulin is a protein present on the surface of the plasma cells, and they are shed. However, with a renal dysfunction, the level increase in the myeloma patient. And albumin also is like the cytokines which are released, like interleukin 6, they suppress the formation of albumin from the liver. And that is why these two markers, which were prognostically found significant based on the statistical analysis done on cohort of patients. However, these were the two landmark studies done in 2015 by Palumbo et al. And another study which showed the revised ISS staging, the revised international staging system. And the R2 ISS is the second version, which was published recently in 2022. So we'll understand what are these staging systems. So the revised international staging combines the tumor burden of the ISS along with the disease biology. That is the presence of high-risk cytogenetic abnormality or elevated lactate dehydrogenase level, the LDH levels. In order to ensure uniform availability, only three widely available cytogenetic markers are used in the RISS. Now, these are the survival curves which were statistically found. So this study actually included 11 international centers trials. It was a multi-center study, and it included 11 international trial centers. And the staging overall survival was found 82% in stage 1, and 62% patients had good overall survival, and only 40% was the overall survival in stage 3. So this was based on the median of till 46 months of follow-up. So this is the overall survival and progression-free survival curves, which are again done on the patients in the three stages, the stage 1, 2, and 3. And 83 months and 43 months were the overall survival. And for the progression-free survival, it was 66, 42, and 29 months for each stage. And they was also done based on the treatment which the patient received. This is without the transplant, with transplant, then with the proteasome and immunomodulatory medicines and the proteasome inhibitors. So the survival, overall survival was almost similar for the post-transplant immunomodulatory and proteasome inhibitors. So RISS was found to be a very robust marker to stage the disease. The revised the R2 version, which is the latest of 2022, this was validated on newly diagnosed myeloma patients. And here the ISS 3 is given 1.5 points, ISS 2 stage is given 1 point, and the high risk genetic marker, which is deletion 17p, is given 1 point, 414 serum LDH more than upper limit is given 1 point, and 1Q plus is given 0.5 points. So this system basically a person just needs to use a myeloma calculator now, which is available online. It is called MDCal, and there are various other AI based tools also. So you just feed in the values of these markers, especially 4 markers used for the revise, and various point system which are used for the R2 ISS. So I'll just quickly go through the RISS, where the RIS revised version has a stage 1 as the same based on the beta 2 microglobulin and the albumin cutoffs, and the stage 2 is in between the 1 and the 3. And the high risk abnormalities for cytogenetics is included in ISS 3 stage along with either this or LDH of more than upper limit of the normal. So if the cytogenetics are not available in under resource, then LDH itself is also a robust marker. But for clinical trials, it is recommended to use RISS. However, a lot of centers like we are now using RISS in our center. And this I will come to a bit later. So I would like to tell about how the cytogenetic risk criteria. So, the cytogenetic risk criteria are basically the standard and the high risk. Sorry, I have some little throat infection. So the standard and the high risk, basically standard are the trisomies which you find 11, 14 and 6, 14 translocation, and the high risk are the 4, 14, 14, 16 and deletion 17p and gain of 1q. So if you have two marker, then it is called double hit myeloma. And if it is more than two markers, then it is three markers or more high risk factors, then it is a triple hit myeloma. The interface FISH is done on the bone marrow aspirate. The mononuclear cells from the marrow aspirate are enriched by the Ficol Hypake gradient centrifugation, which uses a 138 coded magnetic beads. The FISH cytogenetic uses the fluorescent probes, and they bind to the specific part of the chromosomes, and 200 interface cells are counted. So these are the example of how the IGH break apart probe, which is basically they are hybridized to the 14q32 region on the chromosome 14, and the normal cell will have two fusion signals like two yellow signals. However, the aberrant cell, the fusion signal will be separated. So that will signify that there is a translocation of 14 chromosome. Then the 414 translocation, this is a dual color probe where the orange signal, the fluorochrome is bound to the 40 of the fourth chromosome on the P arm, and the green fluorochrome is bound to the 14th chromosome on the Q arm. So the dual color is usually, so there will be like four signals will be present in a normal cell. However, two fusion with one single orange and the green will give rise to tell you about the underlying translocation. So similarly, translocation 1416 and is also a dual color probe. The TP53 is a probe which binds to 17p and another centromeric position. So again, these are the usual signals which you will see in a normal cell, four signals. However, with a loss of one orange signal will signify the loss of 17p. So deletion 17p is a very poor prognostic marker. Now 1114 again is a dual color probe, which is a standard risk cytogenetic. And there will be these are the three color probes. That is why you see 6 signals in this. And this will tell us about the chromosome 13 if there is a monosomy 13. Now in the lab scenario, what we see is this is a fluorescence microscopy picture which shows the IGH gene rearrangement as loss of, again there is a fusion signal, and these two are the separated green and the orange signal, so it signifies a IGH gene rearrangement. TP53 deletion, so there is loss of one signal, and here there is two fusion, one red, one green. So this shows us that there is a translocation which has happened in 414. And this one shows extra red or the orange signal, which is the 1q gain. So I'll just come back to the progress. So disease staging and risk stratification for myeloma, the factors which are considered for high risk of progression in a newly diagnosed case of myeloma will be extramedullary disease. Circulating plasma cells more than 5% is now the cutoff for the plasma cell leukemia, and cytogenetic abnormalities like 1q gain and the other all high risk which we have already discussed, And for the relapsed myeloma patients, so basically once the patient is on therapy or relapses, then also we need to prognosticate the case. And there the disease relapse within 2 years of initial therapy when transplant and maintenance are used, relapse within 18 months in case of non-transplant based treatment, and acquisition of 1q or TP53 deletion can happen during the time of relapse, and the extramedullary disease or circulating plasma cells. So these were the factors which will give you the high risk of progression to myeloma or the relapse. Now I'll just take you through certain real life scenarios. Here, a 68-year-old female patient who is diagnosed with myeloma has a serum albumin of 3.5. So these are the cutoff limits which are given by the ISS, and the beta 2 microglobulin is high, LDH is within normal limits, and the trisomies of 5, 15 and tetrasomies of 9 and 11 is present. There is no high risk cytogenetic abnormality. So this patient would be basically RISS stage 2 with 42 months of median progression free survival. And this was obtained by putting the values on a calculator, or you can form your own table and then refer to it based on the values which are there. So the serum, another patient, 75-year-old male, had a high serum albumin. The albumin was, low. Beta 2 microglobulin was high. LDH was within normal limits, and there were 3 copies of 1Q. So 1Q gain. So 1Q gain is normally known as 3 copies or more. And this came out to be RISS stage 3. So 29 months median progression-free survival is predicted for this patient. Another case, 70-year-old male, diagnosed with myeloma with all the criteria which has been described. Now, once we have, the workup is done specifically for risk stratification to know how much is the overall survival or progression-free survival. And so here in this case, the albumin was high. Beta 2 microglobulin was within normal limits. LDH was on the higher side, and there were presence of 2 high-risk factors, 414 and 1Q gain. So this came as, however, in spite of presence of high-risk abnormality, the RISS score was stage 2 because of the other markers. So we have to take into account all the prognostic markers. 66-year-old male with an albumin of 3.2, beta 2 microglobulin on the more than 5.4. These are the cutoffs given. And the LDH is within normal limits. Trisomies, which are, so there is no high risk cytogenetic abnormality. And the RISS stage is 42 months median free survival. So this is how, basically, just to get an idea how we are doing staging in a real life scenario for a patient using all the important markers like serum albumin, beta 2 microglobulin, LDH, and the interface FISH findings. The last slide is based on the research which is happening on the prognostication tool for the myeloma patients. The high density genomic array, RNA based gene expression profiling, DNA based like CGH and SNPs, and transcript processing based arrays like exon array and microRNA profile, and the proteomics. Proteomics are under investigation. And I think in India also some of the centers are doing projects on these. Thank you.
Thank you, Dr. Ritu, for giving us a very detailed information on prognostication of multiple myeloma and how gradually the system has progressed from simple, from Dury-Salmon classification that we used to do on our PG days to now revised IPSS-2, which includes cytogenetics, and also explaining very explicitly with the examples that how we can go about the staging and prognostication of multiple myeloma cases. There are many questions in the chat box and Q&A. So for all the audience, we will take the questions at the end of the talks. And some of the questions like what is heterogeneity of the disease has already been answered by Dr. Jyoti ma'am in the talk. It's in the chat itself.